What's up, good people? Welcome back to my channel, and in this specific video I'm talking about a very common and very important condition that many patients, especially females, they come to me and they complain about it and they are diagnosed with it. It's called ocular migraine. It's called ocular migraine. There are other migraine videos on my playlist in my channel that you can check about it, but in this video I am focusing in a detailed manner on something called ocular migraine. So let's go over it. So number one thing is, what's the hardcore definition of ocular migraine? According to AOA, the episode of vision loss in one eye in connection or in association with the headache that lasts for usually less than 1 hour is called ocular migraine. Some doctors even call it as ophthalmic migraine. It's one thing for two names for one thing. That's what I'm referring to here, and this is the hardcore definition, how we define it. Well, what are the symptoms about it? How do you know that? Okay, we got the definition, we know that's how the migraine that is called ocular migraine is, but what are the baseline symptoms? Again, this is a long list. You don't have to have all of those symptoms at the same time. Some of them happen, some of them don't happen, some of them happen in one episode, some of them happen in the second episode, some of them happen only in the third episode, and so on and so forth. So you have a blind spot in your field of vision. Usually it's the central field of vision. We call it as central scotoma, which means you have a blind spot right in the center. Sometimes it's off the center as well. Blind spot gets bigger with the time. Initially it starts with tiny blind spot, and the blind spot keeps getting bigger and bigger and bigger until it's a hardcore big time ophthalmic migraine. And mostly, as I mentioned earlier in my definition of the condition, mostly the duration is less than 60 minutes or an hour for one episode, and it can affect your peripheral vision as well. Okay, and usually, almost always, as I mentioned in the definition, it's a episode of vision loss in one eye. So that's why I meant it is almost always unilateral. It can switch the eyes between the episodes, but unilateral, one-sided. Zigzagging patterns. Some people say they see squiggly lines. Some people say they see wavy lines. Some people say they see some kaleidoscope. Some people say they see some zigzagging around their eyes in the field of vision. All of those are part of ophthalmic migraine. Flickering or shimmering of lights. Again, some people think of it as a flash of light, but actually it's the flickering or shimmering of the lights. When you're looking at the light, you will see some shimmer in it. You will see some flicker in it. Usually we don't notice that flicker in the light. Like the light above me, if I'm looking at it, I won't notice the flicker, the absolute flicker. But in this episode, I will be noticing that the flicker or the shimmer or the photopsia in there. Floating lines. Sometimes you see kind of floating lines in there. So those are the things that you need to be aware of. And headache. The headache itself can last for up to 72 hours. 4 to 72 hours is the duration for the headache if you do not treat it. If you treat it, usually it's gone within 60 minutes. And the patient will have some pale look on the face. Patient will have some pale look, some pallor. You can tell from the face of the patient. You can literally look into your mirror and see that, oh God, I look so pale. That will be one of the symptoms and the signs for ocular migraine. Nausea and vomiting, just like a migraine headache. In this headache also, in this thing called ocular migraine, you have something called nausea and vomiting. Some patients start having that even in the beginning, even before the headache starts. They start to have some nausea and vomiting. Loss of appetite. People feel like not eating anything. You don't feel hungry even though it's time to eat, but you're not hungry. Even though you did not eat anything for the last 15 hours or so, and still you're not hungry. So loss of appetite is one of the signs and the symptoms that can happen. But important thing is, You cannot ignore bigger things that come with same symptoms. That's why the doctor who is listening to those symptoms need to be aware of certain other conditions that can, resemble it. In order to rule them out, you need to do certain things. One of them is dilated eye exam. You have to dilate the patient, dilate the eyes, put some drops, and look in the back of the eyes. Because patient has photopsias, flashes, or floaters, you want to make sure it's not a retinal detachment or vitreous tear or anything like that, which is pulling in the back of the eye, causing retinal tear or hole or anything in that connection. So you need to make sure you're ruling out the big elephants. And detailed history about the prior headaches is important. As a doctor, as a physician, you have to take a detailed history from the patient when they come with it. Neurological referral in some cases to rule out the neurological conditions is important. So make sure you are on the track as a doctor. Confrontations, I always do confrontations of the patients to see how is the field of vision, and I also look for the scotoma on the Amsler grade. And FDT, I have FDT in my office. I do it on many patients. I do FDT and see that is there anything else, or how big is the scotoma, and how big is the blind spot, and all those things you can see in that FDT. It's a very easy, quick tool. Persistent blind spot, in your eye exam from the patient complaint, if you're seeing that, or if you're suspecting it to be persistent, then I would recommend doing FDT as well to make sure you're not missing the big elephants. What are those big elephants that you need to make sure? Number one, TIA, transient ischemic episode of a TIA in the brain. Transient ischemic attack. You don't want to miss that, because we have a separate guideline for TIA, and I am sending my patient straight to the ER for other scans and other testing and other management scenarios. Seizures. Sometimes it's one of the types of the seizures that could resemble like this. So you want to make sure you are on the board with the neurologist and ruling out any different type of seizures that could give similar symptoms. Sometimes there is a retinal artery spasm going on. In the back of the eye, there is a thing called retina. I've shown it in many videos. Here is the retinal artery. That retinal artery sometimes can squeeze and cause a spasm of that area and lead to ischemia as well in some cases. So you need to make sure that you are not heading into that kind of retinal artery ischemia, because once a spasm happens, it can turn into ischemia. So dilate your patient, look in the back of their eyes. Sometimes it's an amaurosis with JAKs. Again, these are important differentials. GCA, giant cell arteritis, can also present similarly. Sickle cell anemic patients can have that kind of episodes. Polycythemic patients can also have that kind of episodes. So I would look into more testing if I am getting into any of those suspicions for my patients after taking a detailed history and a detailed eye exam. Another thing is, you need to know what are the triggers. What triggers your ocular migraine? Big time thing is stress. Remember the 3 S's in this condition: stress, smoking, sleep issues. Stress, smoking, sleep issues. The 4th S I can add is strenuous exercise. That also adds into it. So stress, smoking, sleeping issues, strenuous exercise, they are the big triggers for ocular migraine. Okay, besides that, hormonal contraceptive pills can also be part of those triggers. Hypertension, low blood glucose, hyperthermia. Some people get it when they are out in the sun for a whole day and their temperature went up and they start having those symptoms of ocular migraine. So your body temperature can go high and lead to this called ocular migraine. High altitude, people who hike or people who are there at the high altitude for a certain time of the year, they can also get ocular migraine. Alcohol, caffeine, and dehydration. And remember, dehydration is a big one. even though it's at the end of the list, but that doesn't mean it's a minor thing. But dehydration could be one of the times a big trigger for the ocular migraine. So remember those triggers, they are important for you to know about that. Okay, prevention. How can you prevent those triggers? I just discussed the triggers. You need to know those triggers. Make your diary to help you that, okay, what happened in this episode, just write it down in your notes somewhere. Okay, just write them down and track them so that you avoid those habits and avoid those triggers, because certain things can trigger and certain things cannot trigger. So usually it has a benign prognosis. Usually it does not hurt you, but at the later stages, the headaches and all those symptoms discussed, they can cause a lot of problem to you. So be aware of it. The more the aware you are about it, the better you will be about it. Treatment. Take a break. If you're doing dieting, if you're doing intermittent fasting or anything like that, which is dropping down your blood glucose persistently, and that drop down is a trigger for the ocular migraine, take a break from that. Okay, and take a break from alcohol, take a break from stress and all those triggers that I just discussed. Take a break from that. Okay, sleep good. That's one of the treatments. Honestly, stress management is one of the treatments for ocular migraine. So remember those triggers, treat them accordingly, avoid them accordingly. If there is a headache with it, please treat your headache, please treat the pain. Make sure your primary doctor or your neurologist are aware of this and they are giving you appropriate medications for that. Blood pressure control is very important. If you are hypertensive, or if you are diabetic and your diabetes treatment is dropping down your blood glucose too much, leading to hypoglycemia, you need to manage those things. For the blood pressure control, the best ones for this connection of ocular migraine are calcium channel blocker medications and beta blockers. They are the best ones in this regard. Neurological referral or neurologist referral are important considerations for specialized treatment for advanced cases, because sometimes we need to add anti-epileptics, antidepressants, CGRP inhibitors, and so on and so forth. So it has a lot to do with the rest of the body. It's not just your eye, it's not just your brain. It is the whole physiology that we are managing in this regard. So I went in quite a bit of detail, but still there is a lot that I can answer, a lot that I can discuss. So you can ask me in the comment section in case you have any questions. You can share your symptoms in the comment section and discover more things from others. If you have any questions, let me know. Otherwise, have a great day. Bye-bye.